I guess it's starting now.
Okay.
Yes, I think we are live right now. Can you please confirm this law? Yes, we are live. Okay, great.
Live.
Okay. So yes, now we can start. Thank you so much, everybody, for joining us today. We are starting our live now with the lecture with Dr. Alaa Ashkar. Dr. Alaa is one of my very, very good students. She's a PhD student right now in Cairo University. She's almost getting ready for her PhD thesis, right? Defense, inshallah.
And yeah, I hope I get the thesis done first and then I defend it. So I'll make it fast as I can. Yeah.
Inshallah, I'm going to do great. I'm sure it's going to be great. And I'm actually looking forward for it. Thank you so much for doing this effort for us today and presenting this interesting topic. And thank you everyone for joining us. I see we have friends from other countries other than Egypt. So that's why we are making the whole thing in English so that we can communicate. Thank you for joining us. Actually, the reason why we chose this topic today is, I know it's a little bit out of our scope as periodontists or as implantologists, but actually I was very much interested to know about endocrown in our practice because this may affect our decisions in crown lengthening decisions. When can we do our usual classic functional crown lengthening? Is endocrown a kind of replacement for our conventional approaches about functional crown lengthening? Is there a difference, or do we still have to have enough tooth structure? What are the criteria for selecting the cases and all of this? So I'm going to let Dr. Alaa start her presentation. I'm looking forward for it. Thank you.
And thank you. I'm thanking you so much, Doctor, for having me and for the idea of the clinical discussion about the endocrowns. I know it's something that's off topic from the club of the Perio, but let me thank you for the idea for the club, just for the sake of knowledge, spreading the knowledge, people helping each other. And this is really, really meaningful at this time, especially having webinars just for the sake of knowledge, spreading the information you have, since it's evidence-based and things like that. This is really, really valuable. So thank you so much, Doctor, for doing this.
Thank you.
Introducing myself, my name is Alaa Ashkar. I'm a PhD candidate in the fixed orthodontics department, Cairo University. I'll discuss today on the clinical base.
Sorry, I think you are muted, Alaa. Can you?
I'm unmuted now, I guess. So starting with the discussion, it will be a little bit more clinical than the literature reviewing and so, but I'll try to combine both as much as I can. So, I don't know if it's working or not. So as an introduction, well, rehabilitation of the endodontically treated molars, usually they're badly destructed. Loss of the coronal structure is really, really huge. And when you try to restore it, there is a huge risk regarding the biomechanical failure. So there's not a single way to restore it. There's so many ways, so multiple ways. And regarding the situation of the clinical, the clinical situation, you choose the treatment modality you want that fits the case and fits the endodontically treated molar. Well, taking into consideration the best, scientific knowledge, of course, to preserve. So we have to stay conservative and restore the molar back into its function. So how can I evaluate or decide if it really requires something like restoring? Which modality? So I have many modalities in restoring the mutilated, or sorry, the badly destroyed, endodontically treated, whatever the case is. There's so many modalities. There is a decision-making protocol. And with the decision-making protocol, there is the amount of the remaining tooth structure is the most significant factor that influences the choice. Why is that? As you can see in the picture, as the tooth starts losing more and more of its structure, it has a higher risk of failure and fracture. And of course, the clinician skill is one of the determinants as well. So step one, I want to assess the remaining tooth structure. So I start with the three main things that I assess usually in the clinic: the number of the remaining walls and thickness. There has to be a wall not less than 2 millimeter in thickness. The extent of the endo axis. So the if it's endodontically treated, we have many dimensions, including the depth. So you have to evaluate the evaluate it mesiodistally and buccolingually, and the depths as well. The margin ridge condition is very important. It retains the buccal and lingual walls together. So if you lose one of them, you lose like 45% of the strength. So that's why it's really important to have a very thick and not affected margin ridge as well. Of course, the cuspal condition. The cusp is undermined or broken or has a very high load. So it has this might keep you going for cuspal coverage. The ferrule, the thickness, length width. So I might have a very high remaining tooth structure, amount of tooth structure, but the thickness of it is really minimal, so it won't serve, it won't help. So this is very important, and this point in specific is perio-related. Restorative perio related is the defect junction, the junction between the tooth structure, remaining tooth structure, and the restoration, subgingival or supragingival. And the occlusion load is the crucial factor for the longevity. So as you can see, the walls may seem like they're intact and strong, and yet you have to evaluate them with the caliber to decide if they can withstand and be part of your preparation design or not. Second step is choosing the conservative treatment option. So as you can see, there is minimally destructed, moderate, and severely. And Eingel's endodontics before had discussed this issue, treatment modality, or the three of treatment. I actually, and on a personal basis, and as a practitioner, I never saw an endodontically treated molar that only requires composites or just sealing the cavity and that's it. Many they destroyed, or they lack 3 walls, 2 walls, undermined walls, have perfunctional habits, lateral load, a lot of things. So I don't go for composites. I usually do either endocrowns or post-occur and crown for the endodontically treated molars. And why is that? Because as you can see in the pictures, if you restore it with composite, it will break eventually. Why does it break? Because there is something called cuspal deflection. So when the force falls on, the buccal and lingual wall starts to deflect and places one of them under compression while the other one under tension, so it breaks. So it's mandatory to do a cuspal coverage. This is one of the things that I don't want my patient to come over and seek help to restore his endodontically treated molar, and then after a while he comes back with a fractured wall. I don't want that. So there is a way to do something in the middle, not to do a crown and not to do an adhesive restoration, just an adhesive restoration, yet stay conservative.
And we actually get this a lot. We see these fractures a lot in our daily practice.
Yes. Actually, I saw back in college, I saw like 2 cases with the furcation involved as well. They broke the furcation, and I'll discuss why did they broke the furcation. So the tooth will be extracted and then implant will replace it. So it was sad. So that's why we do cuspal coverages. Oh, I'm a pro cuspal coverage, so this is why. So Endocrown combines between the fact that I'm gonna do a cuspal coverage and yet be conservative as well. The history of the Endocrown, before in 1999, Prices, and I hope I'm saying his name right, he was the forerunner of the monoblock porcelain technique. What's a monoblock porcelain technique? It is the behavior of the restoration and the tooth under the load as one entity. So they behave the same. Afterwards, Bindel and Mormon introduced the term of endodontics, and till this day, people are still doing researches. And what's new is the premolar and the anterior endocrowns. They're still under research. There is no rules or certain preparation for them. So that's why it's still under research and still under debate as well. To define the endocrown, it's a monolithic. Monolithic means as a one layer, one piece. And porcelain fabricated from ceramic that can be etched. So it's an adhesive restoration. So it has to be adhered or bonded to the tooth. It consists from, as you can see here, an extension which fits in the pulpal chamber and an external coronal part. So what's the preparation concept and the case selection? Preparation concept, I need retention. So I need to do a restoration that it is retained. If I'm doing a crown, it will encircle the tooth and retain from the whole surface, from the whole external surface. Here, the endocrown will engage the pulp chamber. The already vacant pulp chamber will be engaged and provide the cuspal coverage. Two, it will preserve the tooth. I won't do any external reduction, as well as if I have any minor, and I'm stressing on minor undercuts from the cavity, I can block it and use it in my preparation design rather than removing it or affecting it or further damaging it. The radicular preparation, I have no radicular preparation. I won't place a post. So I'm preserving the dentine in the root. I won't weaken it. And the adhesion, of course, it mainly relies on the enamel margin, the circumferential enamel margin. As you can see in the picture, there is an enamel margin all around, or mostly in the buccal and lingual here, in this case, for the adhesion. So these are the concepts for the preparation. What about the case selection? For the case selection, I need an enamel band to be intact. As you can see here, there's an enamel band intact. This is for the adhesion. I do selective etching and my restoration bonds to it. So this is part of the adhesion, which is part of the retention of the endocrown. I need the walls to be not less than 2 millimeters thick, and the cervical margin will be supragingival all around. The buccal and palatal walls should be intact. Why in specific the buccal and lingual should be intact? Because it's a crown, and the forces fall on the crown if this is the buccal and this is the lingual, and the force falls off from the buccal to the lingual. So this is the way it gets dislodged. This is how I do the resistance and retention forms in my preparation to resist this dislodgement. So here I must have the buccal and the lingual walls strong and intact. And by intact I mean like thick and 2 millimeter thick with the band and everything. Fit the criteria. The pulp chamber should be after the preparation, the occlusive preparation, 3 millimeter. And one of the main indications of the endodontically treated, for the endocrowns is the limited interarch occlusal space. In some cases, I don't have enough occlusal clearance after I prepare my molar, so I end up doing an intervention, a periodontal intervention. Well, endocrowns doesn't do that. Endocrowns allow you to use to restore the limited occlusal space of molars, endotreated molars. So the preparation step, we'll start with the occlusive preparation. With the occlusive preparation, I use like the depth cutters. Depth cutters are like with different sizes, 1 millimeter, 2 millimeter, and 1.5. So I'll select the one and do my depth cuts. And then afterwards, these will be like directing me to just remove the amount I need, which is 2 millimeters. And then afterwards, I will use the diamond burr to remove the tooth structure between the grooves. When I do this flattening, I'll obtain, there's something called the cervical sidewalk will be seen, as you can see here. This is called the cervical sidewalk. Well, this will actually, it may seem like it's not conservative. I'm removing a lot of tooth structure. Well, actually, no, I'm doing something in favor of the tooth and the restoration. How is that possible? I'm placing all the load on the long axis of the tooth. Instead, if this is the sidewalk, then the force is falling directly onto it. Plus, I'm placing the porcelain I'm using, or the ceramic I'm using, restoration, I'm placing it under compression. Well, the porcelain is weak under, the ceramic is weak under tension and strong under compression. So I'm doing it a favor. I'm making it more successful, less failure, less fracture. After I remove, yes.
Can I interrupt you for a second? Can you please go back to the previous slide?
Yes.
Because I think this is an important part of the preparation. You mean to say that we remove any kind of thin or undermined enamel until we reach
you can see I use the depth grooves to do the cuts where I need to stop only, like for, if you can see here, this is the 2 millimeter. Yes. It will cut till the 2 millimeter and stop from here. This part will stop it. It won't go further. It won't go deeper or further. So this is actually like a guidance. So you don't remove more than the 2 millimeter you want. Okay. But as you can see, like there's ridges and some elevations here. You with the wheel burr, or the wheel stone, you remove all of this. So you obtain just a flat surface, a completely flat surface.
No irregularities, no cusps, no
irregularities.
Yes.
Nothing, no cusps, nothing. As I said, it may look like you're killing it, you're removing a lot of tooth structure, but actually you're doing it a favor. And after removing with the green one, you use the red banded finishing stone to remove any irregularities and finish up the surface and obtain a butt joint. As I said, the butt joint is an easy preparation design. Well, places the forces along the long axis and prevents the tension, places the ceramic restoration under compression.
Yes. It looks like more like our classic finish line. It's the same idea.
Yes, it's more like it, but it's called a cervical sidewalk because it's really to the full length. It's not extending to for the full thickness. It's not extending for like 1 millimeter or 2. It's for the whole wall.
Yes.
Further inside. So.
Okay. Perfect.
Okay. I'm sorry. And then I finish it to prevent any micro irregularities and obtain a flat and smooth, even surface. And this is very important. If you have any micro irregularities, it will act as a stress concentration points for the ceramic restoration, and it might cause like stresses, and later on it will break. So if it's gonna be like this after you finish, you have to finish it to be like this. It's rough, irregular, uneven. Here it is smooth, clean, and with no micro irregularities or any sharp edges. For the cervical sidewalk, there is two different designs. The butt joint I've explained, and the other one is called the ferrule. Let's talk on the picture so it can be easier to be imagined. This is the sidewalk. I removed only the 2 millimeters from the occlusal surface, and then I finished it and polished it, and that's it. Well, here I added an external finish line. So I removed the 2 millimeter occlusally, and then I did an external finish line. Well, it might be beneficial or seem like it's better and retentive and serves in the stability of the restoration, but actually it's more sophisticated regarding the seating, and you might weaken the remaining wall, so which is already questionable. So it's not preferred. The butt joint is most commonly used. Yet the ferrule is used as well, but the most commonly used and the most preferred is the butt joint because of it's easy, and when you seat it, the cervical display in this area acts as a positive seating. So when you place your restoration, it sits like this, while when the ferrule actually it has like an extended margin. So during the seating, it might be difficult. Also, the internal adaptation of when we compare both, the internal adaptation of the butt joint is better. Okay. Proceeding with the axial preparation. So we have the axial preparation and the crown as well from the external, but in the pulp chamber, we do it from the inside. So I removed any minor undercuts I blocked. Now I'll like draw the outline. So for the mandibular molars, I'll draw the outline should be trapezoid, and you have to do a rounded line angles. You don't go doing it like around or circular, because you need still a retention and resistance. If you do it like circular, it will certainly rotate. You need something macro retention to prevent it from the rotation. And the triangular, of course, for the maxillary molars, the outline should be triangular. Okay, the total divergence should be from 8 to 10, and by divergence I mean the wall should be slightly diverged, not completely diverged, but slightly diverged. So it will allow the seating better without further friction or having any undercuts or anything like that. Still, some people still question the retention and resistance in the endocrown. How it is obtained? It's actually obtained by the preparation design of the outline. You have to follow the outline, as we said, triangular for the maxillary, trapezoid for the mandibular. Obtain the enamel band you want. You have to have a good enamel band for the adhesion, and follow the slight divergence, not completely diverged or converged. And regarding the when we speak regularly on the retention resistance forms regarding the principles of the mechanical principles of the tooth preparation, the preparation height is something crucial. It's the one that prevents the dislodgement. You see this resistance area? I don't know if this cursor is here. This is the resistance area. This is where when the force falls from the buckle, this area resists. So I don't have this area in the endocrown. How does the endocrown resist this as well? Well, the endocrown takes its retention from the vacant pulp chamber. It's already vacant and it has nothing inside. So I'll take it, and the depth of it is equivalent to the preparation height.
The depth of it is equal to the preparation height.
It's the same idea. When you have the preparation height, I'll go back for the slide. As you can see here, this the height of the one on the left is better than the shorter one, right?
Yes.
And when you have something like the short one, what would you do as a periodontist?
We usually do the functional crown lengthening.
Yes, or we can do like some violation for the perio tissues and do some subgingival finish line. Other dentists do some retentive means, auxiliary proximal boxes and grooves.
Yes.
But here, for what? For prevention or increasing the stability, increasing the retention, right? So this is in case of the crown which encircles the whole tooth. But the endocrown has an internal part that occupies the vacant space, pulp chamber, and the coronal part, right? So where does the retention come from other than the adhesion, of course? Where does it come from? The preparation design and the preparation depth. So that's why I need, when I remove the occlusal, the amount of occlusal I need, which is like 2 milli, I need from the inside at least 3 milli. Adding in this picture, as you can see, the retention is from the inside. Okay. This is what I've been discussing with Hadritic the past 2 minutes. Okay. Regarding the floor of the preparation, I remove the occlusal, and then, of course, before I start, I measure the whole depth before I do anything, any preparation whatsoever, occlusal or whatever. Just measure it. If it's like 5 millimeter, I'll remove like 2 from the occlusal, then I'll have 3 from the inside. This is fine, okay?
And this is the minimum you should have inside the chamber.
Yes, this is the minimum. If it's more, then it's the more the merrier. Okay. Now, what if I did the preparation and I removed, and then I figured out like it's less than 3. It's 2.5. What should I do? I'll shift from the regular preparation design, which is applying the flowable and closing the orifices. I'll show it to you in the upcoming slide. But we'll open one, or like we'll open both canals to have a projection. As you can see here, I'll open 2 millimeter into the canal, okay, in both canals. So I can have take the privilege of the saddle. So that's why it's called a saddle preparation design. So when you do that, you have, and the saddle is the ventine between the 2 canals, actually. So this saddle, I'll use it to add to my stability and retention. Okay. So this is how we increase the retention in endocrowns, rather than encroaching the calling for like crown lengthening or violating biological tissues and so on. This is the restoration, how it should look. However, this design have its shortcomings, so the projections might break, and it is difficult in seating as well. It is a valid design. The most commonly used is to use the flowable composite and place it in the pulpal floor, so you can block any undercuts. Okay, so I'll summarize it, okay, in one picture. So I'll start with the occlusal height. I will remove or reduce up to 2 millimeter, maybe more, but not less than 2. And then the axial depth is the pulp, the axial wall regarding the pulp, or the pulpal depth, chamber depth is like 3 or more. I'll add flowable to seal the undercuts in the floor. Of course, if I have any minor undercuts on the walls, I'll remove it. I will seal it and remove the excess. Circumferential butt joint margin, or the cervical sidewalk, with intact enamel band. So what if my pulp chamber depth is less than 3? I'll shift to the saddle preparation. So this is for the design, for the preparation design and the idea of the design. So let's go to, I'll show you a case, and then we'll discuss how the surface treatment is done, because the bonding protocol is crucial. starting with this. As you can see on the picture on the left, there is a limited, or the interocclusal space is deficient. So if I'm going to do a crown or something like that, I'll definitely call you, tell you, help me, help me. So I removed the second picture. I removed the temporary, evaluated the remaining two structures. As you can see, the walls are very thick. I removed the caries, and I did an immediate dentine sealing. It is recommended to do immediate dentine sealing in adhesive restoration, so it actually aids in the bonding and the adhesion.
Mm-hmm. And also to prevent any, bacterial invasion inside the gutta perca.
Yes, actually, yeah, but actually the bacteria can invade it. Bacteria has nothing to stop it. The bonding won't. It's just in this non-vital case, it's for the bonding sake. In the vital, like in the other vital, like the onlays, overlays, or the inlays, we do them for the sake of the adhesion and for the sealing of the dentine to prevent any further sensitivities.
Mm-hmm.
So I verified the depth, and it was like 4 millimeter. And this is the clearance, the amount of occlusal clearance. And this is the final design, final preparation after the prepared and the global composite applied on the surface, on the pulpal floor. This is the impression, and as you can see, this is the projection. Can you see the pulpal chamber projection here in the? You see how it has like definitive line angles yet rounded. This is how it prevents the. This is how it aids in the retention. It's called the macro retention. And then I do proper isolation for the adhesion. If I didn't do that, any leakage will definitely affect. This is an adhesive restoration, so it will definitely affect the adhesion. Mm. So regarding the tooth, the surface treatment for the tooth, I do the selective etching by applying the acid etching on the enamel band all around, and then I apply universal bond for the tooth, and that will do it. And that will do it. That should be done at the time of the cementation. Hmm. For the restoration itself, I need to bond it, so I use a 9. This is an Emax. This is the lithium disilicate Endocrown. So I use a 9% buffered hydrofluoric acid. I applied it for 90 seconds, and then I washed it thoroughly with water. As you can see, there's a chalky white appearance after drying it. This means that it has been etched. And then I apply silane coupling agent. I usually do the silane aside from the all in all, or the total self-etching cements and stuff like that, because it's better to use each step alone. It serves better and proven to have superior adhesion outcomes. So as you can see, this is another case. This is the enamel band. Can you see the enamel band going all around the tooth? This is the occlusal picture for the endocrown, and this is the endocrown after cementation.
Mm-hmm. Beautiful soft tissue, let me say.
What?
Beautiful soft tissue.
It's soft tissue friendly. It loves the soft tissue, loves endocrown.
Yes.
For the material to be used, well, we know the ceramic classification, or dental ceramic classification, ceramic-like materials. We have 3 main groups: glass matrix ceramics. In the synthetic family, we have the lithium disilicate and its derivatives, which is the Emax and the Empress for the lucite base. We have, of course, the second family is the polycrystalline, which is the zirconia. and the resin matrix is the hybrid matrix ceramics, like the Vita Dynamic and Love Ultimate. So let me show you something. These are what actually we can use for the Endocrown. Why? Because they can be etched and they achieve the monoblock, which is the concept for the preparation, which is the concept for the restoration and the preparation. For example, if I'm speaking about the gloss matrix ceramics of the synthetic, the lucite like the Empress, lithium disilicate like Emax, derivatives of the zirconium reinforced lithium silicate, which is a 10% zirconia added to lithium silicate gloss matrix ceramic, has 10% only of zirconia. It's not zirconia, so people not be confused by the word. Like Self-Stradeo and Vita Suprenti. And these are the blocks, as you can see in the picture. For the resin matrix ceramics, Vita Dynamic. It's the most commonly used on regular basis. Love Ultimate was taken off the market. About the zirconia. Zirconia is not used with Endocrown. Please don't use it because it does not bond. It is unetchable till now. It's unetchable and it does not bond. It won't serve as a monoblock. So it is not used with Endocrown. No matter the lab, whatever the lab tells you, please don't use it. It won't serve. It will debond by time and it won't help you. So you don't want the patient to come over again and ask you the Endocrown. I have it, and he has the Endocrown with him on his hand. It fell off and debonded. It's a failure. So what's new about that? Or yeah, maybe he swallowed it. So what's new about the Endocrown? Is it related only to molars? Well, no, the research is still ongoing related to premolars and molars. Sorry, premolars and anterior endocrowns. Well, as you can see in the picture on the left, they're trying like to do 5 millimeter depth. Let's do another design and stuff like that. Still, there is no definitive design or a preparation design to follow. Why is that? Because the pulp chamber of the premolar has a buccolingual dimension bigger than the mesodistal one. So the behavior of the loading is different than the one we have in the molar, which is has a huge, a better dimension. So the better dimension has better stress distribution. And the same goes for the anteriors as well. The anteriors, as you can see, it's almost conical. Yeah. You have like the dimension of the pulp chamber is really minimal. So this is one of the studies. Still, there's a lot of studies studying the or researchers working on the perfect endocrown for the anteriors and the premolars. And until then, we don't do endocrowns in premolars or anterior. Another research used the endocrown as a retainer, and it was successful. But this is one research, so it is something new. It is something ongoing. I had to mention, but yet it's not something that you do because it has like preliminary study. It's a preliminary result. So something to know, but not to do. For the time being.
Or maybe prepare if you are doing a thesis in the restorative dentistry.
Yes, if you're doing a thesis, definitely this is a very good topic for research. Very good topic.
Yes.
So conclusion. So the success and the longevity of the endocrown are directly related to the case selection, of course, the proper preparation and the suitable ceramic material and the bonding protocol. So at the end, I would like to end with my favorite quote, like the more I live, the more I learn, the more I learn, the more I realize, the less I know.
Yes, I second that.
Thank you.
Thank you so much, Alaa. I'm really, let me tell you, I'm really amazed. It was very simple, to the point.
I'm sorry, doctor. I can't hear you. I'm sorry.
Enjoyed it.
I'm sorry, I can't hear you.
And I'm not just saying this we are.
Doctor, I can't hear you. I'm sorry.
Can you hear me now?
Yes, yes, now.
Hear me? Do I have a problem with the connection?
Yes, there is a problem.
I was just saying,
Connection.
maybe it's a connection problem. I was just saying that I want to thank you so much for your presentation because it was very simple, it was very concise, and I'm sure that everyone here is enjoying. Looks like everyone is enjoying.
Thank you.
It was really interesting, very interesting. And I have to tell you, I'm sitting here as a student of my student, which is very interesting to me.
This is a huge honor.
No, really, really. But no, it's not my area of expertise and it's not my area of practice. And I think everyone enjoyed it. We have a few questions. Some questions from me and some questions are in the chat box. So we're going to take it one by one.
Yes.
Okay. So first, I'm going to ask you a very basic question.
Yes.
I think in order to be able to do Endocrown, we should have 4 intact holes in wall, missing mesial or distal wall. You cannot have that.
4 intact, the 4 walls intact? I'm sorry, doctor, I can't hear you, but no, I only need the buccal and the lingual. These are mandatory. They have to be, after the preparation, they have to be thick and not less than 2 millimeter in thickness with the enamel band. If I lose any of the margin ridges or the, I have like the mesial or the distal affected or a little bit defected, it's okay. Unless you have a very high occlusal load, like a parafunctional habit or something like that, you have to break the habit first and then treat the case, or do both actually.
Okay.
But is it mandatory to use the 4 walls? No, it's better to have the 4, of course, but it's not mandatory.
So then if you have a missing mesial and distal wall, you're going to do the ferrule preparation. But
no, I actually no. Actually, I won't do the ferrule preparation. In other cases, I might have a defective mesial. I haven't like I don't have the mesial, but I have the distal, and the distal wall is like defective or a little bit subgingival. In some papers, they use like the deep marginal elevation or the marginal relocation. They relocate it with composite to be supragingival first, and then they actually do the endocrown. Proceed with the endocrown preparation.
Yes. Okay. The second question is about the choice of materials. We know from your presentation, from the evidence that you brought, that you cannot use zirconia because of bonding and etching issues. You can use either the glass or the resin materials.
For me,
do we have any evidence, or do you have a person which is going to perform better?
For me, as a clinician or the well, actually, as a clinician, I use the Emax usually, which is almost the golden standard. I didn't work with the Inamic before, the Beta Inamic, which is the example for the resin matrix ceramics. I'll check for a paper that that actually evaluate both on the terms of the bonding or the fracture or something like that, and I will forward to 100 definitely. But I don't have a paper right now ready for this.
Okay. Difference between the bulk preparation and the ferrule preparation. Do you have a personal preference which to use? Of course, we know that the is much cheaper, but do you
is the question related to the comparison between the ferrule and the bud wound? Am I correct?
The bud, and do you have evidence which is better? Yes.
Oh, okay. Well, actually, as I said, the butt joint is easier as a preparation because you just flatten the surface and you smoothen it up, even it up, and that's it. It's better for the seating. It does not complex. It doesn't make the preparation design more complex. So, in terms of the complexity, it is much easier. Okay. So this is the butt joint. For the feral, it is indicated, and some people prefer it in cases of the if your walls are thick. It requires thick walls. If you have thick walls, you can do it. If you don't have, and you will have also an enamel band, a good enamel band, you can do it. So this is minimizes its use because of the selection. Okay, this is one part of the selection. The second part is related to the seating. It is difficult in seating, and according to the papers, they showed that the feral, the internal adaptation, in terms of the internal adaptation and the margins, the butt joint is far better than the internal adaptation of the feral. So that's why the feral is not as easy as it may sound. The butt joint is better. However, in my practice, I use butt joint. It's easier and it's more practical for me. Cost of seating and the enamel band is better, thicker, can be used with almost every.
Yes. So I'm going to read some of the questions we have in the chat box.
Okay.
We have Dr. Mahmoud. Thank you for sharing us. He has 3 questions. Okay. On how to do crown in case of retreatment, in case there is no laser device available. If you need to do retreatment of the...
There's no what available?
If available.
Let me open. I can't hear you, doctor. I'm sorry.
Laser device. Laser device.
Laser device?
Do I? Yes. Okay. The question is how to remove the endocrown in case of retreatment of the endo. Okay. سيبك من اللينك.
خلاص. Okay.
Yes.
Okay. تمام. I found the question. Okay. Without a laser device? How to remove it without a laser device? Actually, I don't know. I don't know how to remove it. I'm sorry.
Yes.
I wish I had the knowledge to tell you so, but actually, I don't know. Yeah, I don't have an evidence-based answer to give it to you. So I'm sorry. But yeah, if it's my case, I would try to refer it to someone who has a laser device and worked with it, because I didn't. And if I did not get this chance, I will break it. I will break it into half and then try to remove it in like 2 pieces or something. But I don't have the answer or the perfect answer for this, or the evidence answer for this. I look it up and hopefully I find the answer. Thank you for this. Thank you for the question.
A lot of my endocrown cases end up by vertical root fractures. Most of them had one margin deficient, either mesial or distal. In the preparation design, I did not restore the missing margin with composite, but let the endocrown design the margin. So is my design wrong?
Okay. This is the part where I was telling you, doctor, you have to like respect the saddle. When I said the saddle part, you don't increase the length by removing the part between the. Let me open the slideshow so I can explain it on the picture. He removes maybe I don't know, doctor, if you remove more to have more depth. I don't know. Maybe this
is my connection better now, or do I still have?
It's a little better. Yes, it's a little bit better.
Okay.
So if you can see here, this is the saddle. If you remove this dentine, the dentine between the roots, you will definitely destroy this the integrity, the structural integrity. You're validating the dentine. Okay, you're not preserving it. So if you remove it to flatten, if I flatten it like this, just to increase the depth, it will definitely break. It will act. This part of the dentine won't handle the loading falling on. So that's why it will break. This might be one of the causes. The other cause, if you use flowable composites here to seal the opening and the undercuts in the pulp, the pulpal floor, actually the flowable composite here acts as a cushion. Okay, and it when the stresses falls off, it will distribute it and act as like a cushion. So it prevents the fracture. So maybe if you don't remove from the floor, from the dentine and on the pulpal floor, this is maybe one of the things that you are doing. And the other thing is the flowable composite. You have to apply it. You have to apply it. It's a cushion. Please, when you have like the 3 millimeter, use the flowable composite like for 1 millimeter or something, but don't use a lot of flowable composite. Don't exceed the limit of 1 millimeter. I need just a small layer to act as a cushion. I don't need more than that.
So maybe it narrowed the occlusogingival height of the pulp chamber, you mean?
Maybe he was compensating for the depth, that he didn't have enough depth. And I saw many cases like that. They were removing from the floor just to increase the depth. So, and it's not possible. If you don't have this depth, just open the 2 orifices, extend for 2 millimeters, make them enough for the bulk for the porcelain, and this is more than enough. This is how it goes, how it should go.
Okay. Dr. Mahmoud's third question is about the use of flowable composite on the floor. He says, what about the polymerization shrinkage of this composite? And is it better to use resin-modified glass ionomer instead?
Well, and all the papers I've read and I've known of use the flowable composite rather than the resin, the import glass ionomer. Okay, this is one. 2, actually, I'm not feeling it as a restoration, so I'm not afraid of the polymerization shrinkage. I'm using it in terms of blocking the undercuts, the minor undercuts, and for it to act as a cushion, not as a restoration. I'm not restoring it with composites, so I can be worried by the polymerization shrinkage. Aside from all this, you're going to use resin cement to cement it afterwards. So it's just for the sealing of the minor undercuts and for the cushion effect or the cushion action I want from it.
Okay.
And thank you for the questions, Dr. Mahmoud.
Yes,
they're really lovely. Thank you.
Yes, very interesting question. Okay, we have a question from Ahmed Asraf. He's asking you about the floor preparation. He was asking about the floor preparation. If you can repeat the floor preparation. This was his question.
Repeat them? Okay, yeah, sure. No worries.
He was asking during the presentation. I don't know if you still need this question, Ahmed. I think you repeated it after we asked it.
Okay. I can repeat them if you want to.
Okay. خلاص لا بيقول لك no خلاص. Because after the question, you repeated the whole preparation again, so we're good.
Okay, perfect.
Okay, let's see the other question. Marwan is thanking you so much. A lot of people are thanking you so much. Thank you for everyone. Okay, I have a question regarding provisional restoration for Endocrown. This is really good. I don't know the name, it's anonymous. He's asking about provisionalization for Endocrowns.
Okay. So actually, if you have like a CAD cam, you can do like a PMMA or any restoration like chair side. You scan it and then maybe you can mail it into Emacs. You don't need to do the temporary part. Well, actually, I take like I do like a WhatsApp before I start with the case, and then I do an index. Followed with this index, I fill it with the Pro Temp or whatever material I'm using, and then I reapply it inside the patient, replace it inside the patient's mouth, remove it afterwards. Comes out with an Endocrown. Actually, I remove a little bit from the inside walls just to make it more easier for me to remove it. when I cement it, I use a non-eugenol containing cement, temporary cement. As eugenol intervenes with the final polymerization of the resin cement, the final cement. So that's why eugenol, non-eugenol containing is something important to be used when you're performing an adhesive restoration or doing something related to adhesion.
Let me ask a simple question. Can't you just put temporary filling until you get the...
I can do that. I can do that. But in some cases, I do the temporary. In some cases, but other doctors and other clinicians see like you can place the temporary and that's it. Yes, you can do that, and it's valid.
Okay. I have a final question. I don't think we have further questions in the chat box. So I have a final question. When is it impossible to design an endocrown? What is the absolute contraindication for designing an endocrown?
The absolute contraindication for the endocrown is when you have no walls and no enamel to bond to.
Okay.
If you go,
but not the chamber height, because if you have a short chamber height, you extend your preparation.
Yes, it's one of the things we can compensate for. Like if you don't have the floor, if the depth is not like 3, you can do the 7. Okay, and it is something that it's doable and so. But actually, if you don't have the walls, okay, like one of the cases I had where let me see if I have the picture of it. 1 second. So just it looked normal and everything, but when I measured the thicknesses of the walls, I figured out like it can be done. It was less than 2 millimeters. So I'm sorry I don't have the pictures here.
It's okay.
If the buckle wall is not intact or defective, if the forces are heavy and it's loading, if you are going to alter the occlusion, okay, you might use it as well, but sometimes we use crown. But actually, you can use endocrown in alterations like that, minor ones. Okay. If you have, I don't know what to tell you else. What else?
You said if you don't have
enamel is very important for the adhesion. So the enamel, the walls, the buccal and lingual walls are mandatory. The thicknesses of the walls and the biting forces. If these criteria are not established, then the risk is getting higher. Also, if you're let me tell you something about the post and core cases. If you're not gonna achieve proper isolation for the bonding, if you cannot isolate it for bonding, it's an adhesive restoration. If you cannot perform one of the adhesion protocols proper, then this is a risk also. But actually, Endocrown is so easy. You can use it. It's like a joker, so you can place it anywhere and can be done in the motors, unless the walls and the adhesion are not there.
Yes, I think this sums it up. And really, I really enjoyed today. This happens, but not a lot. I really enjoyed this one. It was really concise and it's full of important information, new information for me. So thank you so much for your effort, and I'm very thrilled that we finally got to do it.
Yes, it has been like a month and a half, maybe, like something like that.
Yes, thank you for your time, and thank you everyone for joining us.
Thank you for having me. Thank you for this lovely opportunity, and thank you for this club and for the spreading the knowledge. And I hope like I did something. I made my teachers and my professors proud because they taught me this, and my colleagues as well. They taught me a lot. So I would like to thank you and thank them for everything they've done to me. So thank you so much. Thank you
so much, and hope we can meet again, inshallah, in the education.
Soon. Thank you, doctor.
Thank you, everyone, for joining us, and see you soon, inshallah.